please. Thank you. So I want to thank the organizers for inviting me here today. This has been great. I haven't been to AIOC for a few years now, and I haven't been to India for 3 years, so this is really nice to see everybody in person and be able to talk to people. I'm going to give a very short talk. I know you're looking forward to hearing about cross-linking, but the talk I'm going to give about is sort of related to the previous talks about keratoplasty. So what do you do when you don't have corneal tissue? I have no financial interest to disclose. So what are some of the reasons why we do keratoplasty? So some of the optical reasons where you want to improve the vision of the patient. You have therapeutic indications where you want to fix a problem that you see on the cornea that you can't fix otherwise. And then there's a tectonic indications where you want to treat the cornea or maintain the structure of the cornea because the cornea is getting damaged. So why do we need alternatives? Why not just do keratoplasty in everybody? Well, some of the reasons are better known to you than to me. In the US, we have plentiful tissue, and we never have a problem with corneal tissue, though we did have one recently because we couldn't find Optisol. But there's less corneal tissue. Sometimes the patients are high risk. You cannot take them to surgery. The eye is high risk. They just don't have healthy tissue that you can do a transplant with. And patients who might not have good vision, and then you don't want to waste corneal tissue on somebody who wouldn't see well. You're doing it just to save their eye. And some patients in the US will not take tissue from a donor because it's somebody else's tissue. So here's a patient. We'll start with very simple. So simple, this is limbal stem cell deficiency in this patient that has ectodermal dysplasia. And this is both eyes are similar. So you cannot take a slet from the other eye. And a poor prognosis, young patient, so you do not want to put them on immunosuppression for a long period of time. In these patients, the major cause of decreased vision, and this patient was 660 in his eye, is because they have irregular corneal surface. And all you have to do is put a hard contact lens on the surface of the eye or a scleral contact lens, and his vision immediately improved to 6.6. And why is that? And it's because when you have an irregular cornea, so conjunctiva over the cornea is very irregular, and so light gets scattered and you cannot see because you're seeing irregular images, something like what you would see in keratoconus. If you put a hard contact lens, now you have, can you see my, yeah. So now you have a smooth surface that the light is getting refracted by, and the fluid from the tear film fills in all the nooks and crannies, and the vision improves, and you get a nice, sharp focus. But in patients where you have more scarring, so this is a patient with granular dystrophy, you obviously cannot just put a contact lens on top because these lesions are deeper. So they're deeper into the stroma, though they are extending into the epithelium, as you can see, but they're pretty diffuse and confluent. So patients can't see with a contact lens. And so what you need to do is you do PTK or do a keratoplasty or keratectomy with epithelial masking. So you do not take the epithelium off, unlike what you would do with PRK or PTK. And here's a sample of what happens. You've got these granular lesions into the epithelium and into the stroma. When you start lasering, you see the autofluorescence from the epithelium. And as you laser down, you laser epithelium here and then just the lesions in the center. And so you'll start seeing the lesions appear. You'll still see autofluorescence from where the epithelium is intact. But where the lesions start showing up, now what you're doing is lasering epithelium in some places and the lesions in the other, the granular lesions in the other. And as you keep moving down, now you eventually end up with a very smooth cornea. This patient actually had deeper lesions too, which we could not remove, obviously. But he did really, really well, is 7.5, and has maintained this for at least 7 years now. So he's very happy, has never needed a transplant. This patient, though, unfortunately had very poor prognosis. HSV, herpetic keratitis, recurrent episodes, could not resolve this with medications, and he kept getting intermittent epithelial and stromal disease. And so what we ended up doing was a very, very thin Gunderson flap. They just wanted ambulatory vision, was an elderly patient, and even through this Gunderson flap, they could get 660 vision, and were very happy because now they had serum-based growth factors in the cornea that prevented them from getting ulceration. Similarly, with this patient with a neurotrophic ulcer, this is a peripheral ulcer, so you don't have to cover up the entire cornea. You can put a pedicle graft over the eye. The neurotrophic ulcers develop because there's no growth factors, there's recurrent trauma, so they cannot heal themselves. There's no tear film. If you put a pedicle graft over the eye, now they've got serum-based growth factors, they've got fibrovascular tissue that doesn't get ulcerated very easily, and this patient maintained very good vision through the central cornea, despite having this conjunctival flap in the periphery. For these really tiny peripheral ulcers or lesions, this was a patient that one of my residents tried to remove a rust ring using a drill and went right through the cornea and got a nice little hole, flat AC. And all you have to do is put glue on there. The glue stays on there for 3 months or so. Epithelium and stroma grow back underneath, and you get fibrovascular tissue. The glue then falls off, and this patient never needed surgery with 6/6 vision permanently after that. So this was a very good outcome. What you don't want to do with glue is to remember that when glue polymerizes, it forms a little mountain on the eye. And so what you don't want is this excessive glue, because then you cannot put a contact lens and keep that glue from falling off because the lid keeps hitting it. One other way of doing that, especially if you have a very large lesion, is to use the drape method, which we use a lot. Take a punch and punch out a little disc of drape. Take glue and put the little disc of plastic on the Q-tip with some ointment on it, and then you put some glue over that. And now what you do is dry the eye. You always want to make sure that the perforation is very, very dry before you put glue on it. Otherwise, the glue will polymerize to itself and not to the edges of the wound. So dry the ulcer, and then put your little drape with the glue on it on top. And now you get a nice little flat disc on the eye. The eye is very, very smooth, and this can stay there for months, and you put a contact lens easily over it rather than a big mountain of glue. Sometimes you want to get some, glue is very inflammatory. It's good for peripheral lesions, but not very good for central lesions. So if you want to treat a central lesion, and especially if you want to reduce the inflammation in the eye, what you can use for these patients, this patient had poor prognosis, had a meningioma removed, so did not have good visual prognosis, and so we put a multi-layer amniotic membrane on the eye, and that got incorporated into the cornea, the epithelium grew over it, and she never needed eye surgery, was very happy because she didn't need to go to surgery. Sometimes you really have to take out your tool belt and think your way through things. This was a lady who had a PKP 25 years ago, so very old PKP, fell and hit her eye on the doorknob and came in, had left her cornea on that doorknob, so she came in basically with an empty eye. You could look into that and see her optic nerve. The vitreous was gone, the iris was gone, the lens was gone, and the cornea, of course, was gone. She was eating when we walked into the emergency room to see her, so anesthesia refused to take her to the operating room until she had done NPO for 6 hours. And so we had an empty eye, and we had to figure out what to do. So what I did was we took a bandage contact lens, a simple AccuView, zero power contact lens, put it on the eye, and glued the edges of that to the eye to form a pseudocornea. And then we put a larger contact lens on top, and this is how she maintained her eye until we could take her to surgery the next day to get her eye fixed up. So take-home points from this: if you have an optical problem, take a look and see what's causing the optical problem. If it's an irregular surface, you can put a hard contact lens on it to smooth the surface, and you'll get good vision without needing any surgical procedures at all. If it is a scar or granular dystrophy or other things that are blocking the vision, do a PTK or a lamellar keratectomy to remove that scar, and you'll get good vision. If it's a therapeutic indication where you need growth factors, put either conjunctiva on there, or you can put a bandage contact lens. And for tectonic lesions, you can put conjunctiva, you can put glue. Glue is actually a really good alternative for peripheral ulcers permanently. And then you can also use amniotic membranes or Tenon's capsule. That's it for a short presentation on alternatives to keratoplasty. Thank you.
Thank you, Dr. Sonal.